Welcome to a brand new episode of Seize the Moment podcast. And today we have a very special guest. Today we have on Mark Ruffalo. He's a psychotherapist in private practice in Tampa, Florida, and serves as Assistant Professor of Psychiatry at the University of Central Florida College of Medicine. He's also an Adjunct Instructor of Psychiatry at Tufts University School of Medicine. He has broad clinical experience in the psychoanalytic treatment of mood disorders, personality disorders, and psychosomatic illness, and has particular interest in the psychotherapy of schizophrenia. Mark, it's a pleasure to have you on. Thank you for being here.
Absolutely. I'm looking forward to it. Thanks for having me.
Yeah, and so for those people who don't know, I've actually followed Mark on Twitter for quite some time. I guess what would they call it, like psychology Twitter or psychoanalysis Twitter? I'm not sure like how specific we're going to
I
get
think
here.
the hashtag is psych Twitter. Yeah.
Oh, dope. Okay, cool. I actually did not know that. So what I really love about Mark is he has really nuanced and super insightful takes. So the first thing I want to talk about, and I think this is like pretty much, especially on Psych Twitter, it's a popular topic, psychoanalysis, right? So first of all, Mark, I want to get your background, what your history is, also the kind of the broad, let's say, perspective and the spectrum of, let's say, theoretical or therapeutic models that you work with. And then I also now want to get into the kind of what the understanding of psychoanalysis is today, right? So because most people in the popular conception think of psychoanalysis in very Freudian terms, but obviously on Psych Twitter, there are a lot of fucking psychoanalysts there, right? And a lot of people who are modernizing psychoanalysis. So yeah, so a little bit about your background and then thoughts about psychoanalysis and pretty much your work in the field.
Yeah. So a little bit about myself. I grew up in North Jersey and ended up going to college as an undergrad at the University of Pittsburgh. Which was a great choice for me because Pitt continues to have really solid programs in psychology and psychiatry and social work. And so ended up doing undergrad degree in psychology and then continuing on to grad school there at Pitt for an M.S.W. with a concentration in psychiatric social work. So while I was there, we have a very large university-affiliated psychiatric hospital there, Western Psychiatric Institute and Clinic, which is where I trained during graduate school, and was really fortunate to have some really solid mentors there, both in clinical social work and also in psychiatry. So when I was in grad school, most of my exposure was to sort of manualized psychotherapy, cognitive therapy, behavioral therapy, a little bit of dialectical behavioral therapy, but CBT was the predominant model. I had an opportunity my second year of my M.S.W. to intern on a acute psychosis unit. And one of the psychiatrists there had a really big interest in history of psychiatry, and he really encouraged me to dive into some of the psychoanalytic and the psychodynamic literature on schizophrenia. I went to the library at the university, the medical school library, and in the back corner of the library is, in the dark back corner is the psychiatry collection, and just walking up and down the aisles of the stacks, and saw a book titled "Interpretation of Schizophrenia" by a guy named Silvano Arietti. I picked it up off the shelf. First off, I'm walking, in the psychiatry collection there, and I'm seeing all these names, and I'm like, this guy Arietti, it's a name that ends in a vowel like mine. And I picked it up, and Silvano Arietti was born in Italy, and my family's from Italy, so just cracked it open and took it home, and just really fell in love with working with psychotic patients in long-term psychotherapy. So finished up my training there at Pitt. Ended up doing a psychoanalytic psychotherapy training, and then getting a doctoral degree in psychoanalytic studies. I published my doctoral project on working with schizophrenic patients in psychotherapy, and sort of integrating biological and psychodynamic models in the understanding of this type of problem. So that's a little bit about me. Since then, I've developed sort of broader interests, not only in schizophrenia, but also in personality disorder, in particular borderline personality disorder, which I've been writing quite a bit about lately. And also in mood illness, depression, and bipolar illness. I have an interest in history of psychiatry, history of psychoanalysis, and a few other things. So that's a little bit about me.
And actually, on that topic, I read 6 of your most recent articles that were published on Psychology Today. And I did notice that, if I'm not mistaken, 4 out of 6 of them were about BPD, bipolar personality disorder.
Borderline.
Sorry, yeah, borderline personality disorder. Question about that. What actually interests, like, what sort of piqued your interest in that topic recently? Is it a patient in particular, or something else maybe that sparked that interest?
Yeah, I've had a lot of interest, in that topic of late, and it's it almost flows naturally from an interest in psychosis, and several of the major thinkers in the psychotherapy of schizophrenia. Harold Searles comes to mind. Began his career at Chestnut Lodge and was really interested in the study of schizophrenia, and sort of later in his career developed interest in borderline pathologies as well. The term borderline comes from sort of this classic notion that the patient exists somewhere on the border between the psychoneuroses and psychosis. And so sort of for me, I think an evolution in my thinking. I still maintain a lot of interest in schizophrenia and continue to work with lots of psychotic patients in my practice. But BPD and borderline disorders more broadly have been a more recent interest.
Interesting. I love that. Yeah. And then, so can we now go back to the recent or more modern applications of psychoanalysis? So just to kind of give the audience here kind of a broad sort of, I guess, understanding, or paint a broad picture here. So usually psychoanalysis is, in the popular understanding, at least, it's understood as being like this outdated, outmoded therapy, essentially one that's been discarded by universities, that's mainly taught in, like, let's say, a history of psychology course, or like a history of psychiatry course. So the point here is that when we think of psychoanalysis, right, we think of the person sitting on the couch, we think of catharsis, we think about uncovering unconscious traumas, et cetera, et cetera. Yeah, so can you tell us now a little bit about you, first of all, your training in psychoanalysis, like what specifically you liked about it, what you took away from it, and how psychoanalysis actually applied in more modern contexts?
Yeah. So, much of what's talked about, at the undergraduate level about psychoanalysis is just a caricature of what psychoanalysis today, really is. And Jonathan Shedler talks a lot about this on Twitter, and we're in agreement on this point. As a college kid, what did I learn, about psychoanalysis? I learned about, Freud's stages of psychosexual development, and id, ego, and superego, and and sort of stuff that most analysts haven't really written about or spoken about in at least 30 or 40 years. So I guess in a nutshell, what unifies all of psychoanalytic theory is this idea that there are parts of ourselves that are not known to ourselves, that there's much more to what makes us a human being than what we're consciously thinking at any given moment, that we're driven by all sorts of mental forces that motivate behavior and create conflict, and produce, in some cases, psychiatric symptoms. So it's a depth therapy. It's much different than sort of the more manualized approaches that are in vogue now, like cognitive therapy, which was what I was initially trained in. I was speaking about that, where you focus mainly on the patient's cognitions, their thoughts, and their behavior on a day-to-day basis. And psychoanalysis is much more of a philosophical, takes much more of a philosophical approach to the human mind, and that's appealed to me. Yeah, when you're in training to become an analyst or a psychoanalytic psychotherapist, often that involves your own personal therapy or analysis. Taking courses on psychodynamic theory and therapy, on different applications to psychopathology, and the like. So yeah, it's a theory that I think, it's not popular in academic psychology departments anymore. Really never was. I mean, academic psychology has always been, more quote unquote scientific in its approach, which doesn't mean that psychoanalysis is anti-scientific. That's not what I'm getting at. But psychoanalysis was really popular in American psychiatry, really from the 1920s or 1930s up until really the 1980s, and then you began to see this shift in American psychiatry toward a more biological and psychopharmacological model or approach. And when that happened, really, psychoanalysis was adopted by mainly clinical social work and by, to some degree, psychology, while, there remain, quite a few psychiatrists who still practice and train in or teach psychoanalysis. So it's a model that really has its historical roots in psychiatry, which is why I teach in 2 psychiatry departments. It still is actually required mandatory training, exposure to psychodynamic psychotherapy for psychiatry residents in the United States, which a lot of people don't realize, that residents in the US, psychiatry residents, have to achieve some level, some degree of competence in basic psychodynamic ideas.
Yeah. Yeah. What's so interesting is like, there's this apparent split, which is not necessarily a split. I mean, it's something Alan and I were actually talking about this right before the podcast. So there's this kind of apparent split that seems to be between the trauma-informed people and the more sort of biologically oriented people. So what's kind of interesting is that on the one hand, you have something like psychodynamic theory, which I don't necessarily think that any specific psychiatrist opposes it, but it seems like for, like, let's say the trauma-informed camp, they think, okay, well, that's actually what's happening, right? So you have like the CBT people, the insurance people, and the psychiatrists who are kind of like all in cahoots with one another, and they're essentially trying to kind of medicalize and let's say chemicalize away mental illness, which is not really the sense that I get. And I mean, I'm kind of being more nice about it, but that's really not the sense that most people should get. And so ultimately what you see is this kind of divide that doesn't necessarily feel like it makes a lot of sense. So yeah, Mark, can you tell us about, like, when we think about psychoanalysis, how is it actually, again, going back into let's say the modernization of it, how is it now more so informed by biology, and why is it let's say a false dichotomy to think about biology as opposed to psychology, and let's say trauma as opposed to let's say genetic inheritance, right? So because again, there's this sort of this seeming split, which isn't really a split, between one's genes, environment, etc., one's trauma history, one's cognitions, sort of unconscious thoughts, etc., when it's really all just one thing.
Sure. Of course. Yeah, you asked a lot there, but I mean, I think that I think it's so important to really grasp this idea that that a psychological way of understanding or making sense of a particular psychiatric problem, for instance, um, uh, does not negate or otherwise render impotent biological understandings of that same problem. That these 2 models, these 2 ways of understanding the nature of this phenomenon, can be compatible. We can integrate them. And there's no inherent antagonism between these 2 schools of thought. I think this is something that in one way is like just common sense, right? Like we have a mind that that produces this sort of subjective experience of the world, but our mind is also, it rests in if you will, or is powered by the physical brain, and doesn't exist without brain, right? So so when it comes to for instance the study of psychosis and schizophrenia, right? I mean, we can talk about dopamine, the dopamine hypothesis, which goes back decades, and the involvement of other neurotransmitters in the etiology and the pathogenesis of schizophrenia, while also talking simultaneously and without any redundancy or without any antagonism about sort of the psychological meaning of the symptoms that are the result of the illness. I think this is again, I think it's something that's vital. And I mentioned Silvano Arietti. He really talked about this, back in the 60s, well before there was any biopsychosocial model, which, George Engel was the psychiatrist who sort of pioneered the biopsychosocial model in the 1980s, but Arietti was writing about this stuff in the 60s, this need to integrate, and how we can, see these problems through, multiple different lenses, without rendering any of them, inaccurate. If that makes sense.
Yeah, and what do you suppose is going on? So on the one hand, what you're saying obviously makes a lot of sense, but on the other hand, there seems to be a camp of people who are offended by this. So what?
No, I mean, there just seems to clearly be a bias towards, like, hasn't CBT been sort of like the gold standard of like this is how therapy should be, like at least in the mainstream, but then it's sort of any
CBT
other
therapists themselves call it the gold standard. And I don't know if you saw this about a year or a year and a half ago on Twitter. I, had sort of called somebody out about gold standard treatment, because when you actually pin them down, there was a large meta-analysis of over 50,000 patients, and it studied the efficacy of different types of psychotherapies in the treatment of depression, and found that none of them were any better than any other, right? And the CBT people, like to claim that CBT is the gold standard and the like. Well, when you really actually, sort of pin them down and ask them what they mean by that, well, all they mean is that, it's just been more thoroughly studied. We just have more research on it. We just have more research to support its use, right? It doesn't mean that but the public hears gold standard, and what do they think? They think, it's better than anything else, which is not true. Anything that you fund, anything that you push enough money towards is going to be, thoroughly studied, and we can say, it's a gold standard, right? So
yeah, I mean, Leon's a CBT therapist. He tells me he's superior to all the therapists all the time. I'm just kidding.
Yeah, and then so just tying it back to just different conceptions of mental illness and whatnot. So right, so now I kind of wonder, since you mentioned this, so that this is, I guess, the more cynical view of it, like these kind of marketing tools that people use, especially on social media, right? So when I hear some of the more kind of just to be fair, because I don't want to kind of sort of demonize anybody here, but like, let's say the trauma-informed people, right? So to hear them, I mean, I totally understand where they're coming from. I mean, all of us have a background in trauma care. I mean, obviously, as graduate schools at one point or another, we had extensive. First of all, we were interns, and we dealt with people with severe trauma. But on top of that, we took courses of it. So I guess I wonder, and Mark, this is I guess my question for you, and in just kind of thinking all of this through, I wonder, what do you think is happening when it's like, on the one hand, you have people saying like, listen, it's biopsychosocial, right? I don't know why there seems to be a misunderstanding. We're trying our best. So somebody wrote an article. I always forget his name, and I don't want to butcher it, but he's a popular psychiatrist. I'll look it up in a minute. So he wrote an article today about like debunking the myth of the medical model. And by the way, in my graduate program, we also like learned about the medical model, and I was like, there's no such thing as the medical model. What?
Yes.
Whatever. Yeah. So why do you think there's like these opposing camps where on the one hand you have these people who are misunderstood and misrepresented as biological psychiatrists, and then on the other hand you have the trauma-informed people that are like in some ways kind of hitting their heads against the wall by saying, yeah, trauma matters. I mean, yeah, we know trauma matters, right? So going back into the notion, maybe this is a little bit more cynical, but going back into marketing tools, like, is it that you think that for like the more trauma-informed camp, this is more of a marketing tool, or do you think there's really just some fundamental misunderstanding? So because the medical model and the way people understand it don't exist. Nobody claims that psychiatric illnesses are just genetic disorders.
Sure. So, I think there's a few things there. I want to touch on the trauma-informed thing in a moment. I think it's really important. I do like to joke or quip, psychoanalysis has been trauma-informed since 1896,
right.
When Freud coined the term psychoanalysis. But to the point about sort of there being this medical model that sees psychiatric disorders solely as genetic diseases, or as disorders of the pathology of the brain. This is, there is a kernel of truth here. Like, if you read some writings from some of the really hardcore biologically minded psychiatrists, in the 60s and the 70s, they do make these claims in their writings. For instance, Ronald Feevey, who I admire because of his work on lithium in the United States.
Mm-hmm.
Ronald Feevey championed the idea that bipolar disease is a disease in a very, very medical sense, meaning it is a pathology of the brain, like Parkinson's disease, like Alzheimer's disease, and the like. And that the psychological factors are largely irrelevant in the etiology of bipolar illness. And there is a kernel of truth here historically, that there have been psychiatrists who have made the points that now today we look at and say, well, that's, no one really believes that. Historically, there were some people in the field who did. And I think that was largely, if you look through a historical lens, a reaction to the dogmatic psychoanalytic views of the 50s and the 60s.
Right.
Where, to these analysts, biology was, they didn't even think about biology in their writings and their work. I mean, in the 50s and the 60s. So you had sort of in the 70s, at least in terms of my reading of the history, you did have some psychiatrists who really thought that at least the major mental disorders were wholly biological, just wholly biological entities. And, 50 years later here in 2024, there are very few psychiatrists out there who argue that anymore, right? So, so there's a kernel of truth there. I think the thing that I get so caught up on when we start talking about trauma is, well, first off, when trauma is used as a diagnosis in and of itself.
Right.
All right. So when I used to teach graduate students, they used to come in and they used to do this all the time. I would present a case, case study in front of class, and what's the diagnosis? Oh, it's trauma. It's trauma. It's trauma. Well, yeah, the patient has experienced trauma, and that's likely very significant in understanding the symptoms that the patient is having. But trauma alone is not a mental disorder. Trauma is an etiological factor that we know weighs in some disorders very heavily, and in some disorders it seems less heavily in the pathogenesis of these problems. So when you look at something like borderline personality disorder, a significant majority of patients have a history of trauma.
Right.
When you look at, other types of conditions, it may be less so. So, but, this idea that trauma, and then you do have patients who present and they really have no discernible history of trauma, abuse, neglect at all. And in these cases, well, a trauma model, quote unquote, could not apply. So I think there's just this misunderstanding that if the patient has experienced some trauma, which, by the way, the term trauma has been broadened now beyond any recognition. Trauma used to have a very specific meaning in psychiatry, and now it's, well, everything is a trauma, it seems, which is not to discount the milder problems that, or the less discernible or overt problems in childhood, for instance, that can significantly weigh in the development of a problem. But trauma is not a diagnosis in and of itself, and this frustrates the hell out of me, to be honest.
Yeah. So I want to read a passage from this article that was just posted today. So he wrote, this seems to be the primary problem with the discourse around the medical model. The quote unquote medical model is conflated with the idea that all medical conditions are discrete biological disease entities, an assumption that isn't even true for much of generalized medicine, let alone psychiatry. When people start off with this understanding, they are rapidly disillusioned, but instead of giving up a distorted understanding of the medical model, they end up entirely rejecting the medical approach to mental health problems. And even when they discover that their understanding doesn't align with how the medical model is better understood, they find excuses to hold on to cling on to their disillusionment. So, and this is a quote from another article he wrote, in academia, psychiatrists will claim that criticizing the biomedical model is knocking down a straw man, which I've certainly said before, since they long ago started considering psychological and social factors, what they call a psychosocial model. But I've seen little evidence of this shift. In England, we're still 5 times more likely to be prescribed psych meds than therapy, and the the discredited chemical imbalance theory, which we will certainly get into, that depression is caused by a lack of serotonin is still listed on half of all antidepressant leaflets. So again, I don't really understand that criticism there. So for me, what they're saying in some sense is that here's this form of treatment, which is obviously we call psychiatric medication, psychotropic medications, and it seems to be working according, let's say, to the data, right? So I don't understand why somebody would have to, it seems like, abandon that approach to therapy in order for them to abandon, let's say, I guess the person is essentially saying, well, if you're really saying that we don't have a medical model, that you should be doing away with the pills. So I don't really get that. That doesn't sort of compute for me. If we're saying it's biopsychosocial, why wouldn't medication be a substantial portion for it? So the thinking here is that if we're trying to help people on all of these particular these levels or in these particular ways, then yeah, why wouldn't we try to tackle them? So I guess, Mark, what's your thinking here? Why is it that in order for this other camp, in order for them to see that yes, we are taking trauma seriously, we have to do away with medication altogether?
Yes, I don't have an answer to that, Leon. I really don't know. I have a hard time wrapping my head around that type of thinking myself. I think there is this sense that, well, if the origin of the problem is environmental, if it's identified in that way, if that's how it's located, then treating a problem that originated from the environment or in the environment or as a result of some interaction with the environment with a chemical is in some way flawed or problematic, right?
Right, sure.
Right. And I think the essence of the misunderstanding here is that, well, yes, we can say in some sense that maybe this problem with the environment set into motion a process that led to the development of psychiatric symptoms, but it is the environment in interacting with the individual's physiology,
Right.
right, and the person's genetic composition that is then producing the symptoms. I mean, this is plainly evident when you look at the development of PTSD. You have people who experience similar traumas, and some of them go on to develop post-traumatic stress disorder, and some of them do not. Well, it's not just the environment that's causing the illness. It's the environment in addition to the person's temperament, their constitutional factors, their physiology, their genetic makeup, and the like. So I think there's just an error in conceptualization there by folks who make that argument.
Yeah. And then just to be clear, so the author's name is Weiss of Top, because I want to give him credit for that article. It's a really great piece.
Yeah. Weiss is a friend of mine, and we've written before. He's really good and debunks a lot of the nonsense that we see all over Twitter. So.
Oh, very cool. Yeah, he's a really brilliant guy.
Yeah, I'm just wondering. I mean, this is probably obvious and very on the nose, but that camp that kind of wants to throw away the medical model.
Yeah.
What do you think is going on in their head? Is it that they think that people are being overprescribed medication? Have they seen instances of that?
Oh, so I mean, I have an idea. Okay, so let me just break this up. Okay, so there are some people who use it to sell their therapies. So I'm not going to point out any names. You can find these people on Twitter. It's fucking obvious what they're doing. They are psychologists who charge anywhere from $200 to $300 per session. And so the idea is like, do away with the psychiatric establishment. I'm the one who can really help you, right? I understand you. So there are those people, right? But for the most part, I think so if you have, let's say, a psychiatric condition, and I just want to be clear and not to pathologize, because I don't necessarily think this is pathology per se, but let's say there is a psychiatric condition where you tend to feel invalidated. You tend to feel, okay, there's this environment that doesn't really see me, doesn't understand me. And again, this doesn't have to be pathology, just to be clear. This could be more broad, and there are certainly people in certain times of their lives where they feel that. And I think what they see and what they feel when they're getting, let's say, and this is the way they would frame it, when they get quote unquote medication thrown at them, what they see is somebody who doesn't care, who's somebody who blames and shames and says, okay, this is your problem, right? So the thing with that is that, yes, there are definitely psychiatrists who do that. I happen to have known some. Just like obviously on the one extreme, you have these therapists who are like, yeah, come to me. I'll, it's like it's a great investment in your well-being or whatever, right? There are also psychiatrists who will literally say, yeah, pills is the only thing that we could do for you. Like therapy doesn't work. It's all kind of bullshit. You're for not so many words, you're the problem, right? So the issue here is that what they're seeing in a particularly invalidating environment, which definitely does exist, and also their kind of understanding of what may not necessarily be an invalidating environment is they're seeing people say, okay, it's this and not that. So oftentimes it's hard for people to see that it's like a really complicated thing. And just because somebody is giving you medication doesn't necessarily mean that you are the problem. It just means that it's one way of obviously tackling the problem. But I mean, listen, also to be fair, it's like we as therapists and obviously as psychiatrists too, you have to have these deep conversations with people where you explain to them like, listen, yes, I'm prescribing medication for you, but I'm not saying it's like your brain particularly that's the problem. What I'm saying is there is a chemical issue. There is something that we could do for you medically. But ultimately, I mean, even with the medications, really their point is for the person to stand and withstand therapy. So it's like we're trying to get you to the point where you're able to be consistent with therapy, where you're able to sort of make connections that you wouldn't have made before, where you're able to sort of work on your decision-making skills, you're able to see the world in a healthier way, etc. And yeah, medication is a big boost for that. But yes, there are definitely psychiatrists who don't do that and who just throw medication at you. But my point is to say that, like, when you think about the, tripartite view of all of this, many good practitioners will say, like, yeah, this is just a part of it. And just because, yes, you have this particular label does not mean that you are some sort of defective person. So, Mark, your thoughts?
Right. Yeah, no, absolutely. I agree wholeheartedly. I do want to say, though, I don't want to let pharma off the hook entirely. There was a wonderful book written by the great historian of psychiatry, Edward Shorter, back, I believe, in it might have been 2019 or 2020, The Rise and Fall of the Age of Psychopharmacology. And Shorter, talks about the heyday of American psychopharmacology in the 50s and the 60s and the 70s, where you had the development of really major breakthrough drugs that, for the first time, we had something to treat chronic schizophrenia and these patients who were, really looked quite hopeless and like they would live at a state hospital for the rest of their lives. For the first time, they could be discharged to the community. And over time, what happened is pharma, gained in influence and power and really, there was a lot of shady stuff that went on in the 90s. In particular, Shorter writes a lot about the marketing of second generation antipsychotic drugs and how they were, vastly overprescribed for childhood bipolar disorder, for all sorts of problems, and some of the marketing ploys and some of the trouble that pharma and some psychiatrists have found themselves in. So, there is again a kernel of truth here that we ought not just dismiss outright as being, well, meds work and there's nothing to see here. There is something to see there. When you look at the literature, when it comes to something like depression, psychotherapy does seem to be treatment of choice for mild or moderate depressions. Yet we have lots of prescriptions for antidepressant drugs being given to patients with mild or moderate depression. Now, that may not be the problem of the doctor, who may be a family physician who has only 5 or 10 minutes to spend with the patient. But so there's other other factors at play here as well. But yeah, I sometimes wonder that the anti medication people out there, I seriously doubt they really have any good understanding of the history of psychiatry and what was happening less than 70, 80 years ago in this country and around the world. Were they to walk into a state mental hospital.
Right.
Catatonic patients who were catatonic for 20 years before, the development of benzodiazepines and electroconvulsive therapy. Really severe pathology. And some of it we don't even see anymore, or we see it very rarely because of advances in psychopharmacology. So, I think these all or nothing takes, these, black or white, this black or white thinking is actually, quite diagnostic. I mean, they're idealizing and they're devaluing, right?
Right.
We're good, they're all bad. Those psychiatrists bad. Us psychologists who, don't diagnose anybody, we're good. So.
Yeah.
I used to think like that, actually.
Tell me.
No. I mean, that's just my brief input.
I-
I really did think like that once upon a time, because I had somebody in my family who was overprescribed medication and maybe could have benefited just from maybe talk therapy, a psychoanalytic approach, or CBT approach. And then it actually kind of coded, and I started to identify with this really hard stance against like psychiatric sort of approaches with prescribing certain medications.
Right.
And then I realized, no, that you really should be nuanced about this and really take a look at the big picture and see that, no, these really are effective for a huge population of people. It's not some. Oh,
I have to ask you, man.
please.
Okay, now I got to delve into this just because this is so juicy, man.
Uh-oh.
Okay, yeah, but it's not gonna be
I'm
too.
just
It's
kidding.
not gonna be
I'm
too
joking.
personal. But like, so okay, wait. So I wonder, right? Okay, when this person was being overprescribed, what was your perspective of that? What did you think was going on?
Well, they were kind of acting like a drug addict,
Mhm.
essentially, in the sense that they would just need their pills. They couldn't feel normal without it. They would figure out ways to get that prescription. If they couldn't get it from the doctor, they would go to another doctor. If they
Right.
couldn't get it from that doctor, they would get it maybe on the street or something like that.
Mhm.
And it started from originally the root of the issue with this particular person started with using prescribed drugs in order
Wow.
to, and then they got kind of hooked on it.
Right.
Yeah. So yeah, that was essentially the situation, and yeah. But I realized that having that black or white sort of thinking about it is not healthy, because you're not really able to look at things like on a case by case basis, right?
Sure.
Yeah. There are people, right, like you said earlier, there are people who benefit with that can help somebody withstand therapy
Yeah. Right.
in order to be able to make it through treatment, right?
Right.
And Alan,
Yeah.
we actually share that in common. Some of my very early writing, like right out of graduate school and in graduate school, was sort of from a Sazian perspective. If you know Thomas Saz wrote the
Oh,
book,
can you
The
tell us, Mark? Yeah. He's
Myth
he's
of
an interesting person. Mhm.
Myth of Mental Illness back in 1961. And I actually had personal communication with Dr. Saz when I was in grad school. We exchanged emails and yeah, so some of my very early thinking was sort of, from this sociological sort of social constructionist standpoint. Well, there's no MRI data here. We can't take a blood test and say this person's mentally ill, this person isn't. But thankfully, my now friend Ronald Pies, really who was a student of Dr. Saz's back when he was in residency, when Dr. Pies was in residency. Thankfully, Dr. Pies sort of enlightened me, and we ended up writing a few things together, and that sort of changed my course. But I think many of us actually, if you look, E. Fuller Torrey, who's one of the best known researchers on schizophrenia in the world, founded the Treatment Advocacy Center. Some of his early writing, to my knowledge, was very pro-Sazian, and I think Thomas Saz actually endorsed the book that he wrote. And so I think there's an evolution sometimes in our careers where we realize that, well, maybe things are a little bit more nuanced than I once thought.
Yeah.
Absolutely.
Yeah, and that's what I appreciate so much about your work, your writing, etc. I mean, because there is so much nuance and complexity within it. It's like so somebody, I actually reposted your article and somebody criticized it and said something like, oh, well, any understanding of borderline personality disorder that leaves out trauma is like half formed or something along those lines. What's so interesting about that, it's like, dude, you can't write everything about borderline personality disorder in one 600 to 800 character article. That's like never gonna happen. But you constantly but you constantly have people who, it seems like, again, are trying to find not just fault, but are trying to find offense. And again, what we would call, what they would call actually, the proponents of the medical model. So it's just so interesting to me that we keep going back to the same thing. And then literally like a couple of, I think it was now weeks ago, but it could have even been a couple of days ago. So somebody, a psychologist named Alexander Chris, he wrote an article that was published in Psyche about borderline personality disorder. And essentially I want to give him credit because he actually has a really good insight in it. So he talks about how like with BPD, there's a detachment from a history of oneself, which I actually did not know we've been working with people with BPD for a long time, but I actually didn't know that that was like an actual thing. Nobody's actually mentioned that to me, so I was like, oh, like this is really cool. But with that being said, I mean, his kind of arguments were very similar to the trauma informed camp, where he said things like, well, with BPD, a lot of times, with the DSM criteria, they don't necessarily they don't cover all of it, which is absolutely true. Nobody would deny that. And then on top of that, there's a sort of understanding that like, oh, and it's the same arguments with the DSM criteria. We're talking about symptoms. We're not talking about like core issues, whatever those are. So can we talk about like now how the DSM seems to be used as like this punching bag, for just anybody in the contrarian academic circle or circles, whatever, it could be plural, where they pretty much use the DSM as a punching bag? Because I mean, ultimately, it seems like, in terms of in terms of like let's say academic, I don't know, success or whatever, it doesn't seem like there's really much of an incentive to defend the DSM. So I don't really see many people doing it, but it's become super popular to attack it. So can you first, I want to hear your perspective on the DSM, but then I also want to get into like, again, why is it that this thing that's again meant to try to help people gain the treatment and access to treatment, because health insurance companies are not paying without a DSM diagnosis, they're not paying for your treatment. So how is it that, so number one, what is your thinking on the DSM? And number two is, when you think about the DSM, why has it become the punching bag for, again, most contrarian academics in the field of psychology?
Yeah. Great questions. I do want to begin though with something that you said about trauma and BPD. Anyone who argues that trauma has been neglected in the conceptualization of borderline personality disorder knows nothing at all about the history of borderline personality disorder. They have probably read nothing by Gunderson, who operationalized the disorder for DSM, by Masterson, by Kernberg, by Searles, and by others. All of them talk about relevant childhood factors in the development of borderline personality disorder. If you look solely at the DSM criteria for any psychiatric disorder, none of it speaks about etiology. None of it, unless you're talking about some of the more neurodevelopmental disorders and dementias, right? There's a little bit of discussion in the DSM in the section on, say, Alzheimer's disease about pathogenesis. But DSM is an atheoretical document. It's been that way since DSM-3 in 1980. DSMs 1 and 2 were very psychoanalytic, by the way. I don't know any psychiatrist with whom I work, or even therapist, who really even uses the DSM all that much. They may take it out from time to time to take a glance at it, but it's not like we have it right in front of us as we're working with patients day in and day out. I can't remember the last time I took my DSM off my shelf. So, you're taking a document here that was created really to help research in psychiatry. Robert Spitzer, who was chair of the DSM-3 task force, psychiatry was sort of looking a bit silly with psychoanalysts not really being able to reliably diagnose patients. And Spitzer came along and said, we've got a big problem here. Schizophrenia was being diagnosed twice as often in the United States as it was in the UK. Major problems with inter-rater reliability in psychiatry. So DSM-3 was developed really with the aim of just allowing reliable diagnosis, where you sit two people down and they're going to agree on the diagnosis most of the time. And it's become this, Alan Francis talks about this, it's become this cultural phenomenon. Everybody talks about the DSM, a book that really was not ever all that important in psychiatry. Still, I mean, I teach in 2 psychiatry residency programs. The DSM is not very important in the training of psychiatrists. Sure, you need to sort of know the symptoms of the disorders, but I mean, we spend much more time, teaching from psychiatry textbooks and textbooks on psychopharmacology and psychotherapy than teaching from the DSM. The DSM is just a way sort of to, help us reliably diagnose these different conditions, give a diagnostic code to the insurance companies, get paid for what we do. and the like. But it's become this sort of, like you said, for a lot of academics, this book that people look at and just shake their heads. Well, it's not really all that important in psychiatry. It never has been, to be honest.
Yeah, super interesting, man. Yeah, because again, wait, did you want to go?
I'll say it after.
Okay, yeah, because again, it seems like, and again, this is the more cynical view, is that in some ways the contrarians are looking for some boogeymen to fight, to say, okay, here's us, and this is, in some ways, this is a little bit of a more charitable view of Alexander Chris. So I understand that in his mind, he's standing up for his patients, but also, I mean, like, dude, you're being published, you're being paid to publish. So on the other hand, I'm like, okay, cool, yes, you're standing up for your patients, but you're also attacking this thing that, I mean, it may not necessarily be benign. That we could obviously we should talk about the stigma around it, but on top of that, it's not necessarily anything that does particular evils that any other medical diagnosis would do.
Yeah, actually, while we're discussing the DSM, it might be important to bring up what is the problem of polydiagnosis? Yeah.
It's a great question. It's something that I've written about.
Yeah.
I coined the term, but it's not my idea. The idea is really one that I've borrowed from Nasir Gami at Tufts. Dr. Gami and I have published a few things together on ADHD, and we share this opinion about polydiagnosis, or the practice of assigning multiple diagnoses to a single patient.
Mhm.
This, I mean, if you know anything about history, this was rarely, if ever, done before the 1980s and the 1990s. You have a patient in the 50s and the 60s, for instance, and they had a single mental disorder. They have one mind, they have one disorder of their mind, and this is the disorder that they have. This was the predominant way of thinking for generations of psychiatrists and psychotherapists, going back to Kreplin in the 1800s, and likely before him. Now you see lists of diagnoses, the same patient being diagnosed with 4, 5, 6, 7 different psychiatric disorders. And what I argue, and Dr. Gami argues, is that we need to adhere to a diagnostic hierarchy in psychiatry and the mental health professions, just like they do in other branches of medicine. Which what that means is that if you have a disorder higher on the hierarchy that explains all of the other symptoms, then the patient only has that one disorder. If the person presents with symptoms of anxiety, at times they get depressed, at times they may have transient episodes of psychosis. It doesn't mean necessarily they have an anxiety disorder, a mood disorder, and a psychotic disorder. It's much more likely that patient has borderline personality disorder, in which anxiety, fluctuations in mood, and transient episodes of psychosis are common. So we've got a major problem, and I think that the problem of polydiagnosis leads to the problem of polypharmacy, right? Where you are prescribing multiple drugs for what you think are multiple different psychiatric disorders, right? If you've got a patient who actually has bipolar disease, and they're anxious, and they're not sleeping, and they may have some other problems, well, it doesn't mean they need a drug necessarily for sleep, a drug for anxiety, and a drug for their mood problem. I bet you in many cases that patient, if they were started on lithium, would not need anything for their sleep. They wouldn't need anything for their anxiety. So polydiagnosis lends itself to polypharmacy, which virtually everyone recognizes as a major, major problem, prescribing multiple psychiatric drugs to a single patient. And of course, in some cases, this is necessary and indicated and warranted. But just like we see patients with 4 or 5 or 6 different psychiatric diagnoses, we're seeing patients on 4 or 5 or 6 or 8 different psychiatric medications, which never used to be done. Never used to be done.
Oh, wow.
And do you think this is something that should be standardized, like this diagnosis hierarchy sort of standard? Or is it that just like this is something you'd want to educate psychiatrists about? Because I could see that, yeah, there could be a need for multiple diagnoses. However, if it does lead to, getting several different medications that you might not necessarily need, that's a huge problem, right?
Yes.
It's more money for certain psychiatrists, depending on their motivations, but it's not
I
good
mean, it's
overall.
also hard to differentiate, you
It
know.
is.
Yeah,
It
it's
is.
kind of
Yeah.
hard to say, okay, well, this is sort of the overarching illness, especially when a person does meet the criteria. So that's actually, I
Sure.
guess that would be a pretty solid criticism of the DSM to say, okay, well, what do you want us to do if these people do have comorbidity and do meet the
Yes.
criteria for so? Yeah, right. How do you want us to treat it differently?
And this is a very legitimate criticism of DSM. And DSM says a few things about this, right? You can't diagnose the patient both with MDD and bipolar disorder.
Mhm.
You can't diagnose the patient both with schizophrenia and bipolar disorder, right? But they do this very rarely in the DSM, and much more commonly in other areas of medicine. So, so that is a legitimate criticism of the diagnostic system without any doubt.
Do
Yeah.
you notice in your personal experience, and actually Leon as well, that if somebody is given multiple diagnoses, whatever, sorry,
Mhm.
do the patients who hear, oh, you have ADHD, oh, you have BPD, oh, you have this or that particular, diagnosis, have you noticed that that does anything to, hmm, what's a good word for this? I suppose the psyche of that particular patient, in the sense that they start to identify with that label that's being given to them, and then it can affect their behavior in, perhaps negative ways.
Yeah, you're sort of talking about social labeling theory, which goes back, many decades. But yes, I think this is a modern trend. I mean, I think
Yeah.
that disease used to be something you didn't want to have. You didn't want to get diagnosed with a disease. Disease was a bad thing to have. A disorder was a bad thing to have. If I go to my family physician, he tells me that I have this rare disease. I don't want to have it, right?
Mhm.
But you've seen sort of just the opposite occur lately, I would say in the past decade or so, where people very closely identify, some people, I should say, with their psychiatric diagnoses. And I think this splits two different ways. One is it decreases stigma around mental illness, which
Yep.
is important.
Yeah.
The other is that there's just this sort of rather bizarre, in my opinion, social or cultural phenomenon in which people are sort of gathering these labels and they see themselves only through this type of lens.
Mhm.
And I think it becomes particularly problematic when we talk about responsibility,
Right.
which is an ugly word in some ways in mental health. No one likes to talk about personal responsibility for one's behavior, but when we begin to explain all of our conduct through the lens of a given diagnosis, I think it becomes problematic. But those are sort of questions that are beyond my area of knowledge, but certainly I've noticed the trend you're describing.
Yeah. Yeah.
Yeah,
Mm.
and it could go kind of twofold. So from my experience, so on the one hand, and let me just kind of distinguish here for people who may be interested. So the difference between responsibility and blame, which obviously gets conflated, which is why people hate the term responsibility, is that blame implies punishment. Blame implies you did something wrong and therefore you deserve to have something negative happen to you, right? So we're trying to change your particular behavior through some negative stimulus, right? Or by obviously taking something away from you. But with responsibility, what we're actually just saying is like what was responsible, and it's usually multifactorial. What was responsible for a particular effect? Meaning, if we could change a particular cause, like whichever, maybe even multiple causes, we hope to elicit a different outcome. So it's a little bit more intellectual. Whereas obviously, when people hear responsibility, they think, oh, you're saying it's my fault and I
Sure.
deserve what I had, right? Or I deserved my lot, which
Right.
obviously I would, well, obvious to me at least. That's not what anybody is really thinking. But yeah,
Correct.
usually when people think of labels and they hear, let's say somebody diagnosed them with multiple things, what people often reasonably enough, like, I don't want to say often, but like reasonably often, what they'll say is they'll say something like, oh, it's another thing, so it's like it's another thing that I have to worry about, it's another thing that I might get treatment for. And that's where I would think that there's a kind of I guess a mistrust of modern medicine, where there's a thinking of like, oh, this person is just throwing labels at me because they want me to be a patient for life. In some ways it's like they're kind of like reducing or lowering my self-esteem so I could keep wanting to come to them for treatment. What's
No, no, that's totally. The reason why I brought this up was sort of in relation to the polydiagnosis
yeah.
article, because I could see that being an issue beyond, you're just given one particular overarching diagnosis.
Mhm.
You're given multiple, And then some people tend to
Yes.
identify with those labels they're given,
Yeah.
and just
Yes.
asking if that creates an issue down the line, depending,
Yes.
you know, on the patient.
Right, right, right.
Right.
Yeah.
Wait,
However, sorry.
No, I was just going to say, and the diagnosis du jour is ADHD. We see
yeah.
that all over the place, and I've written
Yeah.
a little bit on that and some of the trouble with that. But I just want to make one last point about polydiagnosis, which is, you know, when DSM-3 was crafted, Robert Spitzer, again, who was the chair of the DSM-3, very influential psychiatrist, who's gotten a lot of, I think, unfair criticism over the years. He identified roughly 12 scientifically validated psychiatric disorders when he looked at the literature. We have a manual now of over 300, you know, different psychiatric disorders. I think a solid argument could be made that there probably are maybe 12 to 20 valid psychiatric disorders, and all of the other disorders that we have in the manual can be seen sort of as resulting from these core disorders. Which you know, I think that's not taught. You know, it's not. So this sort of argument is also made by Dr. Gami, and you know, that we really, you know, when we look at all these different listings in the DSM, well, a lot of these things could be better encapsulated or conceptualized or made sense of as a variation of or resulting from a different validated pathology, if that makes sense. Yeah. And we've made that argument about adult ADHD in a paper at Psychiatric Times, where really, when you look at the data, much of what we call adult ADHD can be explained as undiagnosed mood illness, a disorder of temperament, or an anxiety condition.
Wow.
So
super interesting. Yeah. And then now switching kind of gears here a little bit. So, I mean, we had Judith Herman on the podcast. What was it, over a year ago now? No, actually under a year ago. So Judith Herman, as obviously some of our audience might know, in trauma recovery, she talks about the links between, what we would call, I guess, feminist interpretations of, let's say, hysteria, what became histrionic personality disorder, and obviously BPD-2. So when we think about the trauma-informed camp, I mean, in this respect, especially when it comes to somebody, I don't know if Judith Herman would call herself that, but like her work is brilliant, right? And I would also cite Andrew Scull as well. He's also another brilliant researcher. So with Judith Herman, I mean, so all of what she says in terms of the misunderstanding and the kind of like over labeling of these things is absolutely factually based. So yes, there is and there especially was a time, maybe not so much anymore, but there's still some remnant of it, where you had like particularly women who were diagnosed with these diagnoses, whereas like men were kind of let off the hook, right? So when we think about now trying to form a kind of like a sort of a bridge between these two camps, do you think, well, first of all, how do we now address stigma in a way that's obviously beneficial for everybody? But do you think a great way of doing that is to just to try to find a way where we acknowledge the fact that yes, there is this sort of like you know, unsavory history of these diagnoses, but at the same time, I mean, like you said on Twitter, right? The real question is this disease present? So yes, this disease was kind of misunderstood, also misused, misappropriated, even to some extent, right? And to a large extent. But can we also say, or how do we now kind of again bridge this gap? So do we how do we fuse these two ideas together, where we say on the one hand, yes, it is a disease, but on the other hand, yes, trauma recovery, that is a legitimate book founded in the history of, especially United States history, but in the history of kind of feminist politics, and in the history of the mistreatment of women just more broadly.
Without a question, I think it's a prime example of throwing the baby out with the bathwater, right? And and I respect Judith Herman and her work as well. And you're absolutely right. I mean, you know, I speak a lot, and I write about and post a lot on Twitter about, you know, sort of the heyday of American psychoanalysis in the 50s and the 60s and the 70s. But we have to remember that you know, there was a great deal of you know, there were problems in that era, certainly with the psychiatric treatment of women, which has been, has been discussed in some of the more recent literature from the feminist perspective and the like. And yeah, I can't dispute that, but we ought not throw everything out. Something like borderline personality disorder exists. It's a severe illness. 10% of people with it will kill themselves. It causes the economic costs of borderline personality disorder are double that of major depression. This is a serious condition, and for people to say, "Oh well, it was used historically in a way that was that led to the mistreatment of women," while factually correct, that doesn't mean that such a condition doesn't exist. And I think that we do those women and men with the disorder a great disservice if we say, "Oh, there's no pathology here, nothing to see here." So that's the sort of stance that I take.
Well, and then so what is your thinking about addressing the stigma? Because I mean, in your defense here, because I'm assuming you would say this, you would say, and in this sort of camp of the perceived medical model or whatever, we're not saying that there's no stigma attached to this. Like, again, when I hear these arguments, I'm like, dude, nobody is saying that these disorders and this diseases or whatever diagnoses, that they are not stigmatized. Like, obviously that's a fact. So how would we address that?
Sure. I think this is a complicated question, because I think about stigma as well. Certainly some disorders are more stigmatized than others, and there's been an evolution in the popular conception. I mean, I think years ago people wouldn't come out and say I have depression, and people do that all the time now, right? And I think that's a good thing. At the same time, I think that because of the nature of psychopathology, because psychopathology involves the mind, how we think, how we see ourselves, how we see other people, how we see the world, and how we interact with it, that there will always be some degree of judgment around individuals or stigma around the problems because of the very nature of these problems.
Right.
And I think that's a very unfortunate reality. But when we see, conditions being renamed throughout the history of psychiatry, manic depression was renamed bipolar. There are some attempts to rename borderline personality disorder to emotionally unstable personality, like they do in the UK, right?
Or CTPTSD,
Yeah, or
CTPTSD.
CPTSD, right? Well, I think what will happen over time, because of the nature of the pathology itself, is that the stigma will remain. These are disturbing problems, disturbing to the patient, and at times disturbing to people around the patient. And I think that we have to accept that. It doesn't mean that we have to behave in ways that contribute unnecessarily to stigma. We ought to do everything against doing that, or everything, but I think I think it's just a hard, bitter pill for some people to swallow, is that because of the nature of these problems themselves, they are difficult problems. And
Yeah, I mean,
if that makes sense.
Makes
yeah.
sense.
I mean, do you think that there is some value? So, for like, let's say some of the therapists, psychiatrists, etc., who actually don't want to label or don't want to use the diagnosis in particular, well, they'll say something like, okay, we'll treat these as, let's say, problems in living, or, whatever such term you want to use, where even though they're like, there's a kind of personality disturbance that's maybe more implicitly understood, nobody really overtly in the treatment or in the sessions actually uses that. Like, do you think that there's a value in that? Or do you think there should be, for the most part, a label used, because essentially you need to address the problem head on?
I think it depends on what type of problem you're talking about. I think with narcissistic patients, labeling or diagnosing the patient as having narcissistic personality disorder early in the course of treatment is something that's ill-advised. With a borderline patient, Kernberg has argued, and I agree with him, that the patient has to be informed of the diagnosis early in the treatment course, and explained and help to understand the nature of the diagnosis. So I think this largely depends on the type of problem. It's hard to speak in generalities here. And I think it has to do in part with the individual patient. But I think that the problem of stigma to me is not sufficient to um, is not sufficient not to diagnose a patient,
Mhm.
in my opinion.
Oh, so can you get a little bit into that? So with Kernberg, why would he say with BPD it's actually advisable to diagnose as opposed to like, well, narcissistic personality disorder is more obvious, so we don't need to talk about that. But why BPD specifically?
No, I think, and I see this, like Kernberg does. I mean, we're dealing with a very specific syndrome that has a name, and this is what we're treating. I think that, identifying the problem as borderline personality disorder helps the patient in the early stages of psychotherapy understand, hey, there's something here that maybe I haven't recognized about myself that is contributing to a lot of these interpersonal problems that I've had sometimes for so long.
Mhm.
And it's not to say that the disorder or the diagnosis is given in some confrontational way, or that but the patient ought to be informed of what you're working about. And in my clinical experience, that's very helpful. And rarely, in fact, have I had patients with borderline personality actually, if the diagnosis is rendered in a way that is non-threatening.
Mhm.
Rarely have I had patients, discontinue treatment because they've received the diagnosis. Actually, for many of them, it seems to be something that helps them make sense of the nature of their problems.
Oh, very interesting. Okay, cool. And then so going into just again going back to the sort of medical model, right? So as I'm sure obviously so with Joanna Moncrief, she came out with the study about how serotonin levels aren't linked to depression, and essentially the chemical imbalance theory is a myth. So now again going back to the proponents of the trauma informed model, they're saying, well, there's no biological basis of it, even though we know that medications do work, especially for more moderate depression. So can you tell us a little bit about your thoughts about the chemical imbalance theory, some of obviously Joanna Moncrief's results of her studies, and then so what is your thinking just more broadly about how this is kind of used to again debunk quote unquote
Yeah.
psychiatry just more broadly?
Yeah, I think that the psychiatrist Ronald Pies has written much more eloquently than I have or can speak about this topic. So I point people in the direction of the work of Dr. Pies, Pies. I think that again, this notion that psychiatrists do or really have ever thought that mental disorders are simple chemical imbalances in the brain is a myth. I don't know. I mean, I've supervised now a dozen residents and taught in psychiatry departments for a decade. I had a lot of interactions with psychiatrists and have friends of mine who are psychiatrists. And I don't think I've ever heard one of them seriously use the term chemical imbalance. I don't think they use it with their patients. I don't think I've ever heard it
Mhm.
being used with the patient. So, I think that what people criticize actually is the gross oversimplification of problems that psychiatrists and those in this field have known are very complex for a long time. The oversimplification of these ideas by pharma, who has engaged in this type of marketing over the years. And I think that this has infiltrated public thinking about the nature of mental disorders. But I would be hard pressed to say that psychiatrists have ever routinely used the word chemical imbalance. I may have heard it in the hospital a few times, but this was not something that was ever said regularly, in my experience at least, to patients about the nature of their problems.
Oh, interesting. So, I mean, I guess how would normally a psychiatrist respond if a patient came in and said something like, well, I saw this commercial, I seem to have a chemical imbalance. How does that work?
Yeah, well, I think the way it ought to be handled is we do know that that there may be some abnormalities in neurochemistry in people with your type of condition. We don't know why or um, uh, we don't know why that occurs.
Mhm.
We do know that the medicine seems to help with these certain neurotransmitters, and many people feel better when they take the medicine. And we also know that a whole host of non-biological factors weigh in why people become depressed and why people stay depressed, including your early life, including things going on in your life now, how you think, and a host of other things, including social factors like where you live and how stressful your day-to-day life is based on where you live or what you do for work. But this medicine seems to help people. I think that's the way it ought to be addressed. And I think that most psychiatrists actually do address it that way. I think that the people who don't address it that way often are not psychiatrists. I think you may find people who have limited training, who prescribe medications, who will address things in that simple way. Family physicians may address things in that simple way because they only have 5 minutes with the patient. Right. But I think this is an unfair attack on psychiatry. Again, though, there is again a kernel of truth here when you look historically that, there have been some psychiatrists, some prominent psychiatrists who decades ago would make this sort of argument. I mean, Ronald Phoebe in his book Mood Swing, I believe he even uses the term chemical imbalance to describe bipolar disorder. So, there is a kernel of truth.
I love that. All right, man. Such a great endpoint. Wow. Okay. So just before I say what I got to say toward the end, Alan, final questions for Mark before we go.
Oh, yes. If we wanted to follow you and follow your work, where can we find you?
Sure. At Mark L. Ruffalo on Twitter. At Mark Ruffalo is the actor. At Mark L. Ruffalo. It's drruffalo.com. Ruffalo is Ruffalo. Yeah.
Awesome.
Yeah. So Mark, I just got to tell you, man. So you are one of my favorite Twitter followees, and followers and followees technically, because we follow each other. And then so I love your work, man. It's so incredibly insightful. So even though for the most part, as we run our practices, we don't have as much time as we'd like to read. I try my best to keep up with all your tweets, your articles, things that you have coming out. So it's been super helpful to my work, man. And I just appreciate you being in the field.
Yeah, Leon, it goes both ways. I've learned a lot from reading some of the stuff that you put out as well. So I really appreciate the invite and the chance to chat with you guys today.
Absolutely, Mark. Thank you again so much for coming.
Alan, thanks so much. All right, take care, guys.
Take care.
Talk to you soon. Bye.
If you'd like to follow us, you could follow us at Seize the Moment Podcast on Facebook and on Instagram. On Twitter, we're at Seize_podcast. Like, subscribe, hit the bell on YouTube. And again, thank you so much for watching, and see you next time.